Today we're going to talk about traumatic brain injury. Unless you work in an inpatient hospital setting, you will not have tons of TBI patients on your caseload. You will have some, though, if you work in an outpatient setting or a school. The definition of traumatic brain injury is an acquired injury to the brain caused by external physical force. The two types are open and closed head injuries. We will talk about these two types on the next slide. A closed head injury is a non-penetrating brain injury in which the skull may be intact or fractured, but the meninges are intact. They can range from mild to profound brain damage. Closed head injuries are often more diffuse lesions versus penetrating injuries in that they affect more area of the brain. The cause is often due to a blunt blow to the head, which will cause shearing or tearing of the axonal fibers, or a hemorrhage, which is a brain bleed. The next type of brain injury is a penetrating open head injury. This is when there is a fracturing or perforation of the skull with the meninges becoming torn or lacerated, thus causing a focal lesion, which is when the damage is limited to a small area of the brain. The most common example of a penetrating wound is a gunshot wound. There is a skull fracture and stretching and tearing of the central structures. So which type of lesion is better to have if you have to have a brain injury, a focal or diffuse? Depending on the site of the damage, a diffuse lesion would be usually more devastating to cognition and language than a focal lesion. If I had to pick, I would choose a focal lesion. Do you remember about 6 to 8 years ago, Congresswoman Gabby Gifford was speaking to a crowd and sustained a gunshot wound to the head? Hers was a focal lesion. She had a very good TBI team, including a great SLP. And because of that great team, as well as the type of lesion she had a really good recovery. Her gunshot wound entered and exited her head in a very succinct line, thus not sustaining a lot of diffuse uh, brain damage. So I've heard interviews with her doctor and her SLP talking about how fortunate she was that her lesion was really so focal and clean. Here is more information on diffuse versus focal lesions. For diffuse lesions, damage is spread over a wide area and often extends deep into the brain. With diffuse damage, anoxia and infection often occur, and there is a global decline in skills, so cognition, language, and motor skills. Again, with focal lesions, there is isolated damage to the brain. We see focal lesions with strokes, tumors, and gunshot wounds. There is a severe decline in skills associated with the damaged area of the brain and relatively well-preserved skills associated with the unaffected areas of the brain. Coup and counter-coup injuries is focusing on where the injury is in the brain. When the brain is injured at the point of contact, this is called the coup injury. Now, counter-coup injuries occur when the brain moves inside the skull and the injury is opposite from the impact. So there can be 2 points of injury in a counter-coup injury. Point of initial impact as well as a point of injury opposite from the impact. These are more likely to occur when there is more impact or force during the injury. So the causes of TBI. In infants and toddlers, we see falls and then TBIs from abuse. I think most of you have probably heard of shaken baby syndrome. This is an example of abuse often seen in infants. Shaken baby syndrome is a perfect example of a contra-coup injury. For school-age children, the sports accidents begin as well as children get hit by motor vehicle in motor vehicle accidents. And then for adolescents and adults, they are in those motor vehicle accidents even more. And if in the military, they will sustain TBIs in battle. And then with the elderly, we get TBIs when falling. So, what do we see in someone with a head injury? The physical symptoms can include dizziness, headaches, trouble sleeping, and then they'll have some vomiting and nausea. Not all these things occur, and sometimes people are asymptomatic, which means they don't have a symptom. So you have to really watch them closely. I think we've all heard that if someone has a concussion, don't let them go to sleep because you're afraid they won't ever wake up. That's not really the reason for sure. There are a couple other reasons. The reason you want to keep them awake is you want to see how coherent they really are. Can they respond to you appropriately? Because that's one of the first things you'll start seeing is that their responses don't match up what should be happening. We also have to watch for seizures because once the brain has been damaged, even in a concussion, there is a higher risk to have seizures. In the healing process, also, the brain can overfire and result in a seizure. The cognitive difficulties are the biggest areas of difficulty in TBI. The first one is attention. Before, when we discussed ADHD, we talked about impulsivity being such a big factor in children with TBI that affects their attention abilities. A TBI also causes difficulty concentrating. Their brain is trying to heal from its injury, and because of this injury and some of the physical symptoms like headaches, it is hard to concentrate. Again, memory becomes a problem because of the difficulty paying attention. Problem solving is another issue. And when we get to the end of this lecture, we'll also be talking about some of the different things in treatment that might help all of these. So the executive functioning, this is why they tend to have a second head injury a lot of times because of this problem solving, planning, organizing, decision making, all of those skills that are impacted. And think about it, a teenager, they're already having issues with their executive functioning in their frontal lobe because they're still developing the executive functioning skills. Lastly, these individuals will have language difficulties and with word finding and putting together their thoughts. With behavior, we're going to see a lot of emotional lability. This means that the individual will cry easily and then they'll start laughing all within 2 seconds. People around them don't know why they're crying or they're laughing. These individuals will be just fine and then all of a sudden not fine. We'll also see personality changes. There are changes in the brain. So personality changes are not unexpected. Depending on where the brain damage is, the personality can change in different ways. Because of how coup and contra coup injuries work, there is often brain injury in the frontal lobe, which will affect that irritability and their ability to engage with others. Disinhibition is when someone will say anything. They will call you names. They will say ugly words, use cuss words that they've maybe never even used before. I have heard another therapist talk about a 15-year-old boy she saw, and that when he was walking down the hallway at school, she got reports from the counselor that he would just say whatever came to his mind. And so he was often saying offensive things, she said, especially to the girls. So the counselor had to have him start walking to his next classes before everyone else because of this disinhibition. There is also impulsivity, where they just think and then react and do something and don't think of the consequences. That's why the people around them must give a lot of monitoring because they'll be so impulsive. Just like they see something they want in the street, they'll go right after it, not thinking, I need to look left and right. I might get hit by a car if I don't. Also, depression makes sense because they often understand their differences and the limitations they now have versus what they had before. There is also a lot of grief. But even without those, with the brain changes, depression can definitely set in. Both anxiety and depression are common symptoms that arise after a TBI. With the impulsivity and aggression, and anxiety again can also set in. And then you'll see some mood swings. This often goes with the emotional lability. So they have ups and downs in their personality. Lastly, they can be very aggressive. So there's some anger and aggression that will come out also. Now, not every individual will have every one of these behaviors. These are definitely individualized. Next, we're going to talk about how to assess. Remember, assessment drives intervention just like the other disorders we have discussed. When you've seen one person with a TBI, you've seen one person with a TBI though. Everyone is different. Every brain is different. Everyone has a different recovery. It's very hard to predict recovery. That is why assessment is so important. TBI assessment and intervention planning is not going to follow a developmental pattern. We're not dealing with development in TBI. We're dealing with the cognitive, neurological, language issues. This is different than typical development. We do have what we call a 1-year rule. That 1-year rule is for norm reference assessments. You can't give a person with a head injury a norm reference assessment, such as the clinical evaluation of language fundamentals, the SELF, which is the golden standard for language development in children and adolescents. And we can't use those standard scores with a person with TBI. These tests are not valid on this population during that 1-year period. In fact, they're totally inappropriate. So, for example, you can give a child with a TBI a norm reference assessment one day, and the next week he could be a totally different person. He might not be talking one day, and the next day or the next week he starts talking. Criterion reference assessments are more appropriate during this initial first year. A multidisciplinary team must be involved in the assessment process because there's so much involved. There's the doctor, of course, the respiratory therapist if the child has a trach, and they might have some nutrition issues. Therefore, the dietitian is on the team. The physical therapist, the occupational therapist, speech therapist, neuropsychologist, and then, of course, the parents are a part of the team. The team will focus on finding out the strengths and weaknesses. That's when the team begins to build on the weaknesses. Use the strengths to build the weaknesses. The team is going to be assessing almost daily because the patient can change so much. Because of what the team does is help the individual and family understand, much of what the team does is help the individual and family understand what is going on, why it's going on, and what might happen next. So what are the initial effects after the TBI? What is the assessment team looking and not looking for? First, hopefully the individual stays conscious. If they do, the individual may be confused or suffer from post-traumatic amnesia or PTA. The person could also become unconscious and be in a coma. So what symptoms defines the severity of the TBI? A mild TBI is when there is no loss of consciousness or a loss of consciousness that occurs less than 30 minutes, and post-traumatic amnesia lasts less than 1 hour. A moderate TBI is a loss of consciousness or post-traumatic amnesia for more than 30 minutes but less than 24 hours. A severe TBI, the individual is in coma for more than 6 hours and the PTA lasts 1 to 7 days. When a person is in an accident, the first people on the scene are usually the paramedics or athletic trainers, and they use the Glasgow Coma Scale to determine the level of responsiveness of the person. Look in your book on pages 448 for more information. This scale is used universally. You've even seen this scale used on medical TV shows if you watch them. Pay attention to when they are at a scene of a car accident or bringing someone to the ER. You'll often hear them say, "What's the GCS?" This is the Glasgow Coma Scale. So this is used at the scene of the accident or initially in the hospital, like I said. Even if you do not work in a place that uses the Glasgow Coma Scale, an SLP has to be very familiar with this because wherever you are, if you read any medical reports, you'll read about the GCS score. It ranges from 13 to 15, which is mild. The more the person can do, the better off they are. 9 to 12 is a moderate score. 3 to 8 is a severe and very poor prognosis. So when you look in your book, you'll see that it looks at eye opening, whether one can open their eyes spontaneously, if they can open their eyes on command, or if the person responds to pain by opening their eyes, such as being pinched to no response. And then the motor response, can they obey commands? Do they try to get away if you're trying to hurt them? Can they tell you who they are? Can they tell you where they are? So can they tell you what has happened to them? And so they add all of these three areas, the eye, motor, and verbal response together to get up to a total of 15 points. There are also other factors that determine prognosis, which are the CT scans and then the length that the individual is in the coma. The window of recovery for a TBI as a general rule is 12 months. The doctor where I once worked at our children's house at Baylor, Dr. McDonald, would say that the child will recover 90% of what they're going to recover in the first 12 months. This means of what they're going to get back, 90% of that occurs during the first year. So if you have a patient who is in a coma for 6 months, they only have 6 months to get a good recovery in. So the longer the coma, the less time the patient has for a good recovery. The longer the coma, the poorer the prognosis for the recovery also. So stop the PowerPoint video now and watch the video on the Glasgow Coma Scale. I think it must be nursing students who are demonstrating what is meant by the types of responses or how you would measure the response. The video is a little funny because people are pretending to do this, but it's good information because you can see what they mean by the level of generalized body response. So it gives you an idea of how you would look at a response. So how does function recover? First, we have permanent damage. So there is some damage that never recovers and the patient will never get it back. Next, there is reversible damage, which is temporary. An example would be when your ankle swells after you just injured it and the swelling goes down. This is what happens in the brain. The brain has swelling, the pressure increases and then gradually goes down. Because of that swelling, the blood flow can't get through there with good oxygen. And then it finally comes back. Then the axons and the dendrites that were disconnected through the diffuse axonal injury, they begin to repair and they begin to grow back. Lastly is what we call reorganization. That's when other parts of the brain take over. You see this more in younger children. They just have more of what is called neuroplasticity. There have been children who have had half of their brain removed and are functioning because the other half of the brain takes over. That is a lot of what we do in therapy is we work on getting the parts of the brain that are functioning well to take over for the parts that are damaged. In summary, there are three levels of recovery of neurologic function: permanent damage, reversible damage, and then the reorganization. Next, we're going to discuss the recovery pattern in TBI and aphasia. We will do a whole chapter just on aphasia, but I do want to bring it in here so you can see the difference. There's your rule of thumb. TBI, rapid recovery, is for 6 months, and then significant recovery for 12 months. When someone has had a stroke, there's a shorter recovery period. Rapid recovery is about 6 weeks, and significant recovery within 3 to 4 months. So there is a difference. So someone from a stroke can recover faster than someone with a traumatic brain injury. Lastly, is someone who has had anoxia is going to have the most difficulty recovering because there's so much death of the neurons that occurs due to the lack of oxygen. Not just decreased blood flow, but a complete lack of any blood flow. The Rappaport coma or the near coma scale is often used in hospitals. Our Children's House at Baylor had a little box of stimulus items that we would use to elicit responses such as auditory, visual, olfactory, and etc. The stimulus items is presented, and then the patient's response is measured on a scale of 0 to 4 using the same type of responses that you saw on the Glasgow coma scale. So these same types of responses from that video would be the ones that you would use here. We would have a bell that we would ring by the patient's ear. Hopefully the patient would turn their head to the sound. Next, we would give them commands to open and close their eyes. Could they follow simple commands? We would also flash a light in their eyes to see their response. To check for a response to a threat, we would flick our hands in front of the patient's face. Try this on a friend. Start with your hand in a fist and then open up your fingers as you get close to their face and watch what happens. Your friend should have blinked. Sometimes people with a head injury don't even blink. This would be considered not responding to a threat. To check smell response, we had a little bottle of ammonia and we put it under their nose and measured the patient's response. So go find some ammonia around your house and smell it. It's quite yucky. For tactile, we would tap them on the shoulder or put a cotton swab up in their nose to see what their response is. It's actually very tickly and kind of really weird feeling, actually. To look at a pain response, we would pinch their fingertips. For vocalizations, we would see if the patient could imitate vocalizations or would vocalize in response to any of the stimuli we would present previously. As far as rating each of these responses, level of comas are in degrees. It's not either a patient is completely in or completely totally with it. Recovery is in degrees. It's not like on the soap operas when someone wakes up from a coma and starts talking. That doesn't happen where there's a sudden wake up. It's gradual, more and more awareness of what's going on when they're coming out of the coma over time. Here at the end of the PowerPoint, I'm going to have you watch a series of videos on Audrey. When you listen to Audrey, the difference in her voice from 1 year after to 3 years after is significantly different. So the child or the patient is out of coma. So how is the team going to measure the progress of the TBI symptoms? The Ranchos Los Amigos scale of cognitive function is a universally used measurement by TBI teams. This was developed by a hospital in California that happens to be called Ranchos Los Amigos, so that's how it got its name. This is an 8-level scale of cognitive recovery, and it's based on observations of responsiveness, purposeful activity, orientation, memory, self-regulation, spontaneity, and independence. So each one of these areas is rated on the 8-point scale. Number 1 is no response. Number 2 is generalized response. Number 3 is localized response. 4 is confused or agitated. 5 is confused, non-agitated. 6 is confused, appropriate. 7 is automatic, appropriate. And 8 is purposeful, appropriate. So it's a gradual growth, and the rankings are very subjective. Whenever a patient is discharged, their Ranchos level will be given to the next level of care. So that facility or the person who is seeing that patient for therapy will have an idea of the patient's functioning level. Also on the discharge summary will be the patient's rate of progress through the scale. The faster the progress through the levels, the better prognosis for fuller recovery. Lastly, one of the issues with the Ranchos is that it doesn't consider any physical symptoms. So what do we see in children after they've suffered, or patients after they've suffered a TBI and are trying to reintegrate into life and/or school? I often say that the clients will often hit a wall where demands exceed capacity. We definitely see problems with academic achievement where we might not have before. They are probably going to have problems with higher level language skills, which will show up in reading, writing, and narrative skills. There will be more than likely to be behavior issues, some of which we've already talked about, but we see limited self-awareness, poor planning, decreased initiation, disinhibition, impulsivity, lack of self-monitoring, unawareness of the deficits, aggressiveness, change in personality, depression, and decreased motivation. So now we're going to take a second to talk about right hemisphere brain damage. Your book talks about right hemisphere damage, which we will also talk about in the chapter on aphasia. A person can have any type of injury, but if it results in damage only to the right hemisphere of the brain, the patients will have certain symptoms. And we call this a right hemisphere neurological damage. On page 453 and 454, you will learn about the deficits that you would see in someone with a right hemisphere brain damage. We will talk symptoms in terms of linguistic, non-linguistic, and extra-linguistic damage. With linguistic damage, you'll see the patient does not quite understand everything, especially complex information. These patients with right hemisphere damage will have difficulty following a conversation. They will have difficulty retrieving words and saying them quickly, even body parts. It is likely they have lost their sense of body and where they are in space. These clients will also have difficulty reading aloud, understanding figurative language or humor, and then they'll leave out letters or put in substitutions in their writing. One of the biggest problems is that they will talk and carry on a conversation, but will have difficulty understanding the conversation. They don't get what I call the gist of the conversation. For non-linguistic damage, attention is a huge deficit. When more severe, they will have difficulty with orientation in that they don't know where they are and will have difficulty knowing where they are in space. This goes along with them not recognizing their body parts in facial recognition that we've already talked about. Then slow response time. You're going to say something to them and they kind of have to sit there and process it and wait till they can finally output an answer. A huge characteristic of right hemisphere damage is visual neglect on the left half of the body. So if the patient is walking and there's a table on their left side and they're walking towards it, a person with the right hemisphere will walk straight into the table with their left leg because they don't realize that the table is there. Their vision is just fine. It's not a vision difficulty. They just do not realize that it is there. So for some reason, the brain doesn't really recognize anything on that left side. A common assessment task is to have the patient write their name on the top left of a page. So you give them a piece of paper, and where do you think they're going to write their name if you tell them to do the top left of their paper? They are going to start at the top, but in the middle, because they are not aware of that left side of the page. So at first, when the therapist is training on left side neglect, a very simple thing will be that they'll put an X on the left corner and say, find the X and write your name there. Again, there's difficulty with facial recognition, and some have even reported visual hallucinations, and of course, visual memory. For extra linguistic damage, this is really about getting that gist of the conversation. They will often have difficulty with the big picture and can't put everything together. They will often have difficulty telling about their day because of the difficulty summarizing everything into 1 to 2 sentences. They will miss the overall theme of narratives, conversation, and have difficulty interpreting information and making inferences. We will often see them contribute little substance to conversation and then have difficulty processing emotional content. They almost lose the ability of theory of mind and the understanding of other people, and then the processing about others during their interactions, which can result in difficulty relating to others. So for treatment, there are just a few basic intervention target methods that we're going to discuss here. You will have an entire semester on TBI in graduate school that you'll go way more into assessment and treatment. But in treatment, the therapist needs to remember that the patient will retain what they've already learned, which is very helpful compared to some disorders that are very inconsistent. The team will want to focus on problem solving, of course, and a lot of that executive functioning skills, such as paying attention to details, sequencing, and carrying through a task to help the patient be functional. The therapist may have to gradually build up the time of attention because of cognitive fatigue. A lot of times the therapist will determine a set time in which the patient will need a cognition or a cognitive break, and they'll build it into the patient's daily schedule, especially when they go back to school or work. Therapy must also focus on the patient's ability to become self-aware of their characteristics, especially their impulsivity or disinhibition, the difficulty with concentration, and they'll teach these strategies to self-monitor and teach the patient how to regulate their behaviors. To wrap things up, let's discuss how TBI is different from other disabilities. First, needs with a TBI patient will change constantly during the acute phases of recovery. Recovery and changes may take up to 2 to 3 years and even longer. But remember, the most recovery will take place during those first 12 months, especially those first 6 months. But we can still see changes up to 2 to 3 years later. The TBI doesn't change the ability for the individual to learn new information. The most significant impact is on how that individual learns and his rate of learning. People with TBIs do not lose their intelligence. IQ is still the same, but they do have difficulty learning new information because of their attention, memory, and decreased concentration abilities. Before, if the person could probably learn something with one presentation, now he might need it presented 4 or 5 times to learn it. TBI is often referred to as an invisible injury. Sometimes I wish they could wear a cast on their head or something to show others, so others will understand they're not functioning normally, even though these patients are going to look normal. They maybe will do fine for a while, relying on previously learned information, but problems may not show up until later. So again, at which point do demands exceed capacity, like I've said before? That is when the breakdowns begin to occur. Previously to the TBI, previous to the TBI, the individual probably had normal development. Not always, this isn't always the case, but that is why it is important to understand the person's pre-morbid or the functioning before the injury. Lastly, individuals with a TBI usually retain previously learned information, although they may have gaps in abilities. I hope you've learned and you found TBI really interesting. The brain is so miraculous, and the recovery from a TBI to me is just one example of this. I want you now to watch the 3 videos of Audrey who suffered a TBI. These are located in the materials section of Canvas. I saved these for the end because I think it's going to, now that you've kind of learned all this information, it's really going to help wrap everything up and be a great example of everything for you. So see you next week.